My personal experience was as a family physician in rural Manitoba in 1993. And I was in my office, and on one particular day, a young man came into my office with his wife. He was in his mid-40s. And it was the first time I'd seen him in my practice. And he sat down in front of me, looked very uncomfortable, and said to me that he couldn't live life like this anymore. He was living in severe, severe pain because he had metastatic colon cancer. And I vividly remember feeling extremely uncomfortable with the situation. And looking back, my discomfort was because I'd never received any education in the area. And I asked him what he was on for pain, and he said he was on morphine and he was on very small doses. But I knew no better, so I said to him, I'm sorry, I can't increase your morphine because you'll become addicted. And I remember him looking at me, getting up, and he began to cry, and he said to me, I hope one day, as physicians, you can better look after us. And he walked out of the office.
I had a young man who was 28 who I found as cancer, and it was a very malignant cancer, and he was absorbed by the cancer system. At that time, you know, you referred it to the oncologist, and then you never heard about the patient ever again. Well, I didn't hear about the patient until I was in my office, and I got an urgent call from his wife saying they just discharged him from hospital, and he looked terrible. And I saw him, and he was in absolute agony. And here was this vigorous young man who was bald, had lumps all over him, and he was in agony. And what I found out is they had fractured his neck in the ambulance ride home. And so for me, it was easy. I gave him a shot of morphine, although I wasn't sure how much to give him, sent him back to the hospital, and 6 weeks to the day later, I got another phone call from his wife saying they had discharged him again. And I found him in absolute agony in his home. He had had no pain control for 6 weeks. And I gave him a shot of morphine, and my hands were shaking as I was thinking about giving him another shot of morphine because I was told morphine was dangerous, you know, and was I gonna kill? And as I loaded up the syringe, he died in front of my eyes. Well, that was a Friday afternoon. I was absolutely decimated. And then on Monday, I went to the College of Family Physicians annual meeting, and the first speaker was Dr. Balfour Mount. And the first thing he said, and I'll remember it forever, is people do not have to die with pain. And it was like the heavens opened up. It was my epiphany.
We as Canadians value our healthcare system, and I think we believe that our healthcare system will be there when and if we ever need it for end-of-life care. We believe that the system, the programs, the policies, the healthcare professionals have adequate training, and that the system is properly resourced so that if we ever need it, then it would be there for us. And I say if we ever need it because I think we as a society like to think that death is an option.
I think the biggest misconception of Canadians is that they think those services are going to be out there. And it isn't until they come in contact with the healthcare system that they find it, they aren't there. So they may not be able to get a palliative care bed in a long-term care facility, or they may not be able to get a residential hospice if there is no residential hospice in their community, because they're only in a few of the provinces. And they don't necessarily get all the home support programs that they need in place to be able to do that.
The fact is that you might receive poor quality care. The person delivering care might deliver less than adequate care, and yet both parties feel that, well, death is difficult, death is painful, suffering is inevitable, and therefore optimal care is never really provided.
Do you really want to wait until you're dying before I communicate effectively with you, before I manage your pain effectively? I don't think so.
Palliative care is not a place. It's a philosophy. It doesn't mean the wallpaper on the wall. It doesn't mean, you know, that special room with the flowers and that. But it's an attitude, it's an approach to care. It's a philosophy of care, and it can be done everywhere.
It isn't about the space. It's about having the physician and the nurse and the social worker and the pastoral care and the supports that you need as a family to be able to deal with this, and that's what it's about.
We're actually talking about therapies to relieve suffering and give people the capacity to live their lives to the fullest they possibly can while they fight their disease, and if they happen to get to the point where they're dying, that they'll die safely and comfortably, and their family around them, and they'll be able to complete their business and close their lives, and there'll be people there to support their families afterwards. But that the focus isn't on dying, the focus is on living, because most people want to live, and we can help them do that.
It's as if you had a pair of glasses, and one lens was really focused on the biomedical model, that you want to do the very best healthcare for this person. So you want to do the best symptom management and just provide excellent healthcare. But the other lens is focused on the fact that this is also the person's human journey, and that living and dying is a natural phenomena. And then we need to put this pair of glasses on and keep these lenses in focus in order to have a good, clear picture of what hospice palliative care is trying to do.
To me, it's the concept of anticipating what's going to happen, planning for it, managing it, and walking with the families. And they do completely differently than those who don't get that kind of supportive care.
To really care well for the dying, there needs to also be a focus on wholeness and healing and on the person. So if you will, it's rather than focusing on illness, which happens to be attached to a person, it's really starting from the place of the person who happens to have an illness.
You know, often when they hear the word palliative, they think this is the end. We're in the last few days or weeks of our lives. And it's very frightening. And I think one of the most important messages we have to try to convey to the public is that palliative care is not just about dying. It's not just about the last few days or weeks of life. Palliative care is about improving the quality of life for anyone who has an advancing, progressive illness. But it can be many, many months and sometimes even years before the death. Palliative care is about celebrating life. Palliative care is about improving life.
If we are ever at a point in our lives when we might consider that we could possibly die someday, then we think we have control of when and how that happens. So we don't prepare ourselves. We don't do anything to talk about it with our families, to prepare for its eventual coming for us. We don't understand what's available for healthcare services. We don't focus on it. We don't deal with it because we think we're going to control when it happens.
It's not something that usually becomes, part of regular conversation. It is something that, we know it's hidden in the corners, it's on the periphery, and that's pretty much where we want to keep it. Periodically, things happen in our lives that bring it from the periphery into our more central focus of vision. And when that happens, I'd say one of the problems we have is that we know too little and we expect too little. And that's a dangerous combination.
There's this myth around that if you talk about dying, it somehow makes people live less. You know, it reduces hope. And as one of my colleagues says, well, so if you get another couple of months, what are you going to do with it? What's the hope behind that if there's no cure?
Many years ago, they felt that you don't tell people that you're dying. Now I think we've finally convinced people that it is their right to know, but we don't always tell them they're dying early enough.
So many people think that you have to go to a lovely place and die in a lovely place. I mean, the scenario I like to describe is the old mansion with grandmother in the window, the lovely vase of flowers beside, the family all around, her arms across her chest, lovingly surrounded by her family, is hospice palliative care. Well, I think the chance of most of us dying in that way is pretty slim.
The healthcare professionals today are trained to cure. And so we're not well skilled to face this other end of life which is death. In the last 40, 50 years, we've learned one way of dealing with health, with the disease, with life, and with death. We've looked at death in a very specific way. So now we have to unlearn that.
So many of us went into medicine to save people. So for some people, it's really their own emotions, our own thoughts and feelings that we bring with us that may stop us from sort of seeing palliative care as a successful end to an illness.
Death represents a failure for health professionals. And therefore, because it's a failure, we walk away from it. I think the other challenge is that we're never trained, we're never educated on how to engage someone who's dying or their family. And so because of that, if you're not sure how to do something, if you're not comfortable doing something, you don't do it, you walk away from it.
One of the challenges is that we do have a false dichotomy in my mind between living and dying, and I'd like to see that sort of merge, where we're providing good palliative care, for example, not only to people who are in their last stages of life, but palliative care as a philosophy is embraced by all fields of medicine. And it's something that is incorporated into every aspect of the care that we give.
We have curative or disease-modifying therapy up to a point, and then we have the introduction of palliative care. That is why palliative care is always associated with dying. And I even see lots of us, like if it's not our other colleagues, it's us. We are part of the problem because we say words like, when is the patient palliative? You know, oh, this patient is palliative. Whereas we should be saying, when can someone benefit from palliative care services?
It's getting the word out to people that they should begin to expect that they can ask for all those issues to be addressed by their healthcare team. And I think that's a huge shift. Now, many people say to me, oh, well, we don't want to use the palliative care word because that means the death service. And what I say to folks is, I don't really care what the word is. As part of your healthcare, as you as a Canadian, don't you want me to address the issues that are getting in the way of you living from day to day so that we can do the best possible therapy for them as well?
Physicians should be hardwired to care, and they should be hardwired to provide whole person care. And that may be cure, that may be disease modifying, that may be palliative. And if that were the way they saw things, then I think we could work very cooperatively right from the start.
When I first started in palliative care, we were seen as handholders. You know, it was that denigrating sort of way of looking at palliative care. And the other hand, I don't think we should be going all the way to say that the essence of palliative care is pain and symptom management.
There's an education piece that needs to happen with healthcare providers that aren't palliative care specialists. I think we need to do a better job of telling, you know, oncologists and HIV and AIDS programs and all these other programs, people that are dealing with seniors as they're aging with heart disease, that what hospice palliative care can do, what it should be doing, and why you would want to refer those people to those programs early enough.
We can actually reduce the cost of the system and utilize resources better. So I don't think that it's an either or.
What we really need to get through to people is that palliative care can benefit them throughout their illness.
The important thing is to view palliative care as an integral part of the healthcare system. Palliative care is not just this small specialization that's set aside. And when a patient is now dying, they get moved to a hospice or to a palliative care unit. Palliative care is an approach that's integral within the healthcare system. And so if all of us are practicing the good principles of palliative care, it becomes integrated.
You know, compared to where I was in 1978 when I started in palliative care to now, in the last 5 years, we've seen a tremendous increase in those queues. And I think we're not only coming of age, I think we're creating that niche and are starting to convince others around better care for the dying.